Okay, let's get going talking about the cardiovascular system. We're going to talk about as that relates to perfusion. And, in previous courses, we've talked a little bit about what perfusion is, meaning that the blood flow gets to all of the places that it needs to go to, whether it goes to the brain or the toes or the heart or whatever that is. But that's what perfusion, that term, actually means. And the heart plays the starring role in perfusion. So we kind of have to ask ourselves, what does the heart actually do? So let's talk a little bit about that, and then also like how do we know what the heart is doing? So the action of the heart. There's two different components to the heart. We have the mechanical component, and then we have the electrical component. And so when we look at like an EKG, that's what people get really excited about, learning how to read EKG or telemetry strips. What we're seeing on those strips, all those little waves and whatnot, is the electrical part of the heart. And each one of those waves, P, Q, R, S, T, and spaces and all of those kinds of things, they have a corresponding mechanical action that occurs in response to that electricity that's going off down through the heart. So when we look, for example, at the P wave, that first little wave in the cardiac complex, that's the mechanical thing that's going to happen in response to that is the atria are going to contract. And then when we look at that QRS, that's when we know that the signal is moving down through the septum of the heart into the ventricles, and then our ventricles are going to contract in response to that. So it's very coordinated and very methodical. And we want a specific mechanical response to the electrical response, because if we don't have what we're supposed to see, or if there's an alteration in the way that the electricity is conducted through the heart, or if it's stopped up or slowed down or sped up or whatever, then the mechanical response is going to be very different. So all of that being said, ultimately what happens as that heart beats is blood is squeezed out of the heart so that we can achieve perfusion or blood flow to all the distal parts of the body. And then when it relaxes, or during that diastole phase, then blood can fill into the heart. So that action of squeezing out that cardiac output, that pre-fill, that preload, that refilling of the heart, all of that is impacted by how hard the heart squeezes, how much the heart can relax, how fast the heart is going. And so we have to think about all of those components when we're determining what someone's cardiovascular assessment actually looks like. And in conjunction with the lungs, that heart, that perfusion, allows for oxygenation and oxygenation, nutrition, and gas exchange, and all that stuff in conjunction with the respiratory system. So we need blood flow to get nutrients and to get oxygen to all of the parts of our body, and to be able to get all of the desaturated and waste products back out to be filtered through where it needs to go. There are a couple of things that we need to think about in terms of the heart and blood flow and perfusion, and one of those things happens to be something that we've talked about in the past, that we're not always excited about, but we find that it just keeps coming back to smack us in the face, and that is volume status of our patient. Because as we move along in this lecture and we start to talk about other things like blood pressure and heart failure and things like that, volume status plays a really big role in those different medical problems that we encounter quite frequently within our patient. So we think about perfusion, we think about oxygenation in conjunction with the lungs, we think about the amount of circulating volume that we have. We consider the fact that we have both an electrical and a mechanical component to the heart. These are all things that answer that question, like what does the heart actually do? How do we know what the heart is doing? That's where our physical assessment kind of comes into play, where we look at things like our pulses, how fast the pulse rate is, what the quality of the pulse is, what our blood pressure is. That perfusion, that blood flow, gives color and temperature to our skin. When we have good perfusion to our brain, we have good cognition. When we have good perfusion to our kidneys, we have good urinary output. So we can look at a lot of different body systems, if you will, to give us an idea potentially of how the heart might be impacting one body system or another. We can also look at, of course, radiological exams and laboratory examinations and things like that as part of our assessment. There are a few labs that are kind of specific to cardiac function. A couple of those are termed cardiac enzymes. We look for CPK and a troponin. Those are enzymes that are released in response to muscle damage, and most specifically cardiac muscle damage. So if we're starting to think that there might be some sort of dysfunction, like when we talk about myocardial infarction, we might see an elevation in our CPK or in our troponin. Another lab value that's pretty specific to the heart is something called a brain natriuretic peptide hormone, and we mentioned this briefly in MedSurg 1 when we talked about volume excess. BNP is actually a hormone that is released in response to an increased stretch in the aorta of the heart. So what that means for us when we're thinking about heart and perfusion and volume status and all of that is when there's more volume that the heart has to manage, it creates a greater stretch on the heart. And when that stretch becomes too great, the body is trying to say, hey, there's too much volume here, we need to get rid of it. So that hormone has a target tissue in the kidney that tells the kidneys to get rid of fluid to try to help maintain a fluid balance. And hopefully, if the body's working correctly, then that increase in that hormone will result in an increase in urinary output and thus bring that volume status back to an acceptable level. We could also consider BUN and creatinine as it relates to perfusion. Normally, we have thought about BUN and creatinine in the past as renal function, but if you think about it, in order for our kidneys to function correctly, they have to have good blood flow. And in order for the kidneys to get adequate blood flow, we have to have good perfusion, which is part of our heart and our blood vessels. So we can consider that there's a potential, if there's an elevation in BUN and creatinine, there could be some alteration in the body's ability to maybe perfuse that particular organ. Let's see, what other kind of diagnostics? Sometimes we'll see chest x-rays. We can get an outline maybe of the heart, or we might see if there's pulmonary congestion if we're worried about fluid volume overload. Echocardiograms are basically like an ultrasound of the heart. We can see what wall motion looks like. We can see what valves are doing in there. There's a variety of different tests that you can do to tell us a little bit more about heart function. Stress tests, EKGs, that's a common one. So your book goes into greater detail about all the different diagnostic and radiological exams that you can do for the heart. So that was just a little bit of a quick review of the heart and what it does and what we're going to be kind of looking at here. And so we're going to move on to our first, our first medical problem, which is the idea of blood pressure. And blood pressure is something that we've probably seen a time or two at this point in our nursing school career. And we have to think about blood pressure in terms of what determines our blood pressure. So how does our body know what our blood pressure is? And what is a normal blood pressure? And what is too high of a blood pressure? And what is too low of blood pressure? And why are those things potentially harmful for our patients? So there's basically two things that determine someone's blood pressure, and that is volume status and vascular resistance. And so if you think about it, the more volume that is circulating through the vessels, the harder the heart has to work to push that volume around, and so the pressure in that system is going to be higher. Additionally, the more resistance that the heart has to push against, or stiff vessels or sclerosed vessels, narrowed vessels, what have you, the higher that pressure within that system is going to be. And so we think about those things because when we start to think about treatment for someone who has an elevated blood pressure, we're going to be affecting one of those, or if not both of those components, that volume and that vascular resistance. We know from fundamentals courses that standard textbook blood pressure normal is 120/80. There are a variety of different standards that we'll kind of look at a little bit that kind of tell us what's too high and what's too low and what our target numbers are. And sometimes that those goals differ depending on a patient's history or age or different things of that nature. And when we think about like what's too high or what's too low, again, that can be determined by the condition of the patient. When we talked about neurological function in a patient who is having an ischemic stroke, we discussed how we wanted that particular patient's blood pressure to be higher than what we would expect to be normal, because we're trying to perfuse the brain in a scenario in which there's a narrowed vessel there. Now, that's not the case for everybody, but just an example that what our target for blood pressure may not always be 120/80, which is the standard textbook normal blood pressure. We're going to have to kind of start looking into those gray areas to consider what's going on with my patient that I need their blood pressure to kind of be like, where do I need it to be? As far as what's too low, well, that's where we think about that perfusion. Like if my blood pressure is not high enough to maintain perfusion to my organs, then my blood pressure is too low. And typically when we're concerned about that type of low blood pressure, where we're concerned about perfusion to organs, we really are looking at the what's called the mean arterial pressure. And we know that when a mean arterial pressure or a MAP is 65 or greater, then we are probably going to have good perfusion, especially to kidneys. So just, something to kind of keep in mind there. Just a fun fact, I guess. Hypertension is what we're going to start out with here. We're going to talk about elevation in blood pressure. It really affects millions of individuals in this country alone, not to mention all of the billions of people across the world. We have two basic types of hypertension, what's known as essential or primary hypertension, and then a secondary hypertension. So essential hypertension is an alteration in peripheral vascular resistance, heart rate, or stroke volume. And basically those are just more words for what I just discussed about vascular resistance and volume. It can be for a variety of reasons, but oftentimes there really is no identifiable cause. It's just maybe some sort of genetic issue that's going on. With secondary hypertension, what we're looking at here is diseases that impact the functioning of blood pressure. So a lot of times renal disease or kidney dysfunction is a big cause of a secondary hypertension. Some sort of condition that might interfere with sodium excretion or renal perfusion, glomerulonephritis. So the kidneys, you'll learn, play a big role in blood pressure control and management. So it's definitely something that we have to consider. We see it all the time. Now, there are non-modifiable risk factors and modifiable risk factors. Those things that are non-modifiable, these are the types of categories in which we look at individuals and say, okay, you fit within this category, and so you need to have education about how to manage blood pressure and monitor yourself for blood pressure. So if we have a family history of hypertension, individuals who have a lower socioeconomic status have been known to have a higher blood pressure. Older people, certain ethnicities such as African Americans, these are all just, there's a high correlation between these non-modifiable risk factors and hypertension. So we need to watch these people, educate them about how to reduce the risk of hypertension on regular routine provider visits and whenever we're interacting with them. But we also know that there are things that have been shown to increase a person's blood pressure, and this is where we can really make the biggest impact. So whereas these non-modifiable things are factors that we can't change, I don't know why it keeps doing that. Our modifiable risk factors are really where we can make a big difference. Certain disease processes like diabetes, elevated lipids or high cholesterol levels, an increase in sodium intake, sedentary lifestyle, high stress lifestyle, smoking, excessive alcohol intake. All of these things we can knock out or control to help reduce the risk of hypertension in our patients. So if we look at these risk factors, these modifiable risk factors, we can kind of see a couple of things happening here. The thing can kind of lead to the need for the heart to work harder, or it might make the vessels more stiff or less pliable. In other words, we have an increased vascular resistance, or perhaps some of these are damaging the vessel in some sort of way. So when we end up with vessels that are damaged, for example, smoking leads to stiff blood vessels, which can lead to interior vessel walls that are not functioning the way that they're supposed to, and can lead to buildup in plaque and less pliability. Diabetes can lead to alterations or damage within blood vessels. That is going to drive me crazy. So apologies for that. So, when we're looking at what are these things causing that are leading to blood pressure problems, they're altering volume status, they're altering vascular resistance, they're causing damage to the blood vessels in the long term. Oh shoot! I have my notes here. I just closed them. Now I'm gonna get a bunch of warnings. Okay. Over time, an elevated blood pressure can lead to some pretty significant damage. The heart is what is most affected by an elevation in blood pressure, but we can also see effects within the kidneys and the brain, and even within the vessels themselves. So we start to notice that there is an increase in the size of the left ventricle. So if you think about any other muscle, when we exercise or work that muscle, it gets bigger. And if we're trying to work out and become stronger, like that's a really great thing. But we don't really want our heart to get bigger. So when our heart has to work harder to push the blood or against the increased resistance that we have in our body, then that muscle, that left ventricle muscle, becomes bigger. And when that takes up more space with muscle, that means there's less space for blood to fill in. So we end up with a decreased cardiac output, which means our perfusion is altered. As far as our kidneys go, that prolonged elevation in blood pressure can lead to damage within those small vessels. They can become thick, they can become narrow, which increases vascular resistance, again, which is going to make it harder for perfusion to occur. And if we aren't getting good perfusion to our kidneys, then our kidneys are going to start kind of pooping out on us. As we start to beat on those blood vessels, as blood flows out to all of our tissues, they can kind of become weakened. If our heart is working really hard, there's a high pressure that it's pushing against, and it can kind of stretch out, lead to weakened walls. We can have aneurysms, we can have rupturing, whether that's a stroke rupture or even something very dangerous, like an aortic dissection. Essentially, the aorta just kind of starts to split apart. So that's just some long-term complications and problems that can happen because of elevated blood pressure. All right, so what is our patient going to look like if they're experiencing an increase in blood pressure? Well, there may be no signs and symptoms early on, and yet all the while damage is occurring to those blood vessels. People may feel just fine. Hopefully, during routine visits, we're able to catch an elevation in our patient's blood pressure, but as the hypertension progresses, over time, patients might start to have some of these symptoms that you can see here on this slide, things like a headache, they might have palpitations, they might have blurred vision, maybe nosebleeds, and all this is because of an increase in that within that pressure system. So what are our goals for blood pressure as far as numbers and treatment? So this is a little bit of kind of a medical perspective in terms of what the recommendations are for the management of elevated blood pressure in adult patients. So you can see that it's a little bit different in terms of ranges and when to start medication therapy, as well as what kind of disease processes the patient might have that would indicate that we need to start therapy. So again, just kind of as I mentioned before, there really isn't a black and white. There's a little bit of a gray area. You can see if someone is 60 or older, the recommendation is to start drug therapy when a blood pressure is at 150/90. But if you're less than 60, we want to start that a little bit sooner in terms of what the blood pressure is. And with this type of treatment, we're looking at lifestyle modifications, and we're also looking at a variety of different medication types that will manage volume status as well as vascular resistance. We want to give time for those medications to start working, and so this may require follow-up visits with your provider to see if the patient is responding to one drug or another, or one treatment or another, or whatever. And I'll talk just a little bit more about medications here in a couple of slides, and you'll definitely learn more about medications as they relate to blood pressure in your pharmacology class. So overall, from a nursing standpoint, we focus on education and lifestyle change. We want to make sure that the patient is taking their medications like they're supposed to. One thing that you'll see happen is a patient will start to take medication, their blood pressure will get better, and they'll say, I don't need my medication, my blood pressure is good, when really the only reason their blood pressure is good is probably because they're taking their medications. So we want to make sure that patients are compliant with their medications. Part of compliance and facilitating compliance is going to be that we educate patients about side effects, things to expect from these medications. Some of the medications that are used to treat blood pressure can have some unpleasant side effects, and so when we tell a patient what to expect, they're more likely to be compliant because they expect they can kind of see these things coming, and they can be less distressing. If a side effect is enough for a patient to stop taking a medication, then it really isn't serving its purpose, and we kind of need to consider that perhaps there should be some other medication that we need to perhaps trial the patient on. So we want to educate them so they can report those side effects to us. We want to make sure that we are keeping an eye on cholesterol levels, atherosclerosis, arteriosclerosis, that plaque buildup and stiffening of the blood vessels. We want to keep our total cholesterol numbers under 200. Now, total cholesterol is comprised of both LDL and HDL. So LDL is the bad cholesterol, and HDL is the good cholesterol. So you can kind of see those numbers up here with cholesterol, LDL, HDL, triglycerides. Those are goals on where we would like to keep our patients' numbers there. And we also know that diabetes can play a big role in hypertension, and so keeping our A1C and our blood sugars within good goals. A big thing I think that we really have to think about is how can we modify lifestyle. What were those things that we talked about that can increase blood pressure? Things like diet, exercise, alcohol, that kind of thing. Weight reduction is a huge thing that can help with blood pressure. Even as little as 10 pounds can reduce the systolic blood pressure by 5 to 20 millimeters of mercury. So encouraging weight loss through dietary modification, heart healthy diets like low fat, low cholesterol, and exercise. Exercise is good not only for weight reduction, but also for increasing aerobic capacity and overall cardiac health. It's recommended that aerobic exercise be done 40 minutes most days of the week. That's the most beneficial as far as recommendations go. And also strength training and flexibility can help to help with lowering blood pressure. Another dietary component we have to think about is sodium intake. We know that water follows sodium, and we know that an increased amount of fluid or volume is going to increase our blood pressure. So if we start to consider decreasing the amount of sodium that we're taking in our diet, that's going to be helpful. There's something called the DASH diet, lots of fruits and vegetables, low fat, low cholesterol, good proteins, lean meats, healthy fats. things like that are just going to be good for overall heart health. It's recommended that alcohol is consumed in moderation. There's some guidelines here for that, as well as smoking cessation. Nicotine not only increases our heart rate, but it also increases vascular resistance, both of which can contribute to an elevation in blood pressure. And then stress is another thing that we sometimes forget, that can lead to an elevation in blood pressure. So teaching things like relaxation techniques and stress management are going to help with reducing blood pressure. These are all things that you think these are really great ideas to do, but they can be kind of hard. Those lifestyle changes are really kind of challenging. I can tell you that personally, about a year ago or so, I noticed when I went to the doctor, my blood pressure was getting a little bit higher and higher. I think it was like around 140/90 a little over a year ago, and I mentioned that to my doctor and was telling him, it seems kind of high. I'm not really a tall person. I don't need that high of a blood pressure. And so I really made some significant lifestyle changes. I started eating better. I started drinking more diet, less, just less of all of the crap food. Exercising, I lost quite a bit of weight, about 35, 40 pounds. And just introducing some stress relieving things within my lifestyle. So weight reduction, sodium restriction, healthy diet, adding exercise, adding relaxation techniques, all of these things I just did, over the last year. And the last time I went to the doctor, a couple months ago, there was quite a significant decrease in my blood pressure. It was, like I said, like 140s/90s. And this last time it was back down to like 110s over 60s or 70s. So, lifestyle management can really have a significant impact on blood pressure. Okay, a little bit about medication. So in pharmacology, you'll talk more in depth about these medications. So just a kind of a quick rundown or a review on what kind of pharmacological interventions can we expect for the patient who has hypertension. Let's start with diuretics. There are a variety of different types of diuretics, everything from potassium-sparing diuretics to loop diuretics to thiazide diuretics. But basically, diuretics are going to talk to the kidneys and tell the kidneys to get rid of fluid. So if we remember that blood pressure is determined by volume and vascular resistance, diuretics are getting rid of that extra volume, and thus they are decreasing the blood pressure in our patients. Now, they're not usually going to have a significant drop in a blood pressure, but they are going to be able to help lower the blood pressure in patients. We do have to consider that these medications work on the kidney, so we want to monitor renal function on our patients if they're using diuretics. We also have to remember that an expected action of this medication is that the patient diureses. So just, making sure that the patient knows that after you take this medication, you're going to have an increase in urinary output. That's expected. So perhaps take care in regards to the timing of administration. You probably don't want to take your diuretic right before bedtime, because then you're going to be up peeing all night long, which is going to be miserable. So, we oftentimes tell patients don't take it after 5 o'clock in the afternoon. That way it has time to work before you're actually getting ready to go to bed. Let's see. Depending on the diuretic type, whether it's a potassium-sparing diuretic, a loop diuretic, a thiazide diuretic, you do want to keep an eye on electrolytes, whether that's sodium, potassium, magnesium. They all have their own little things that they have to watch out for, but we want to keep an eye on that. Calcium channel blockers. These medications work by blocking calcium from crossing over channels. That's the cellular issue that's going on, but ultimately what happens is they result in decreased vascular resistance. So there is a little bit of diuresis that can occur with calcium channel blockers, but for the most part what we're doing is we're causing vasodilation. And so if the blood vessels are more dilated, there's less for the heart to push against, and so it's going to lower the blood pressure. Again, there's quite a few different examples of calcium channel blockers that are out there. They tend to have the word dip in them, like amlodipine is one. Also the acronym very nice drugs, verapamil, nifedipine, and diltiazem. Those are all calcium channel blockers, just different examples of those medications. Okay, ACE inhibitors are pretty much a first-line treatment for hypertension. These are your prils, like lisinopril. And these medications also cause vasodilation, which means the heart's going to have less to work against. Couple of fun facts about ACE inhibitors: they can cause hyperkalemia, so we want to keep an eye on our patient's potassium level as well as their renal function. They also have been notorious for causing angioedema, so we want to make sure that we're educating patients about how to recognize signs and symptoms of angioedema, which I'm not going to go into because we talked about that last semester with hypersensitivity. Another annoying thing about ACE inhibitors is they can cause a dry hacking cough. That is a normal side effect, but it can definitely be something that reduces compliance with the medication. ARBs, angiotensin receptor blockers, these work on the renin-angiotensin-aldosterone system as well, and ultimately result in vasodilation. Because both ACE inhibitors and ARBs work along different parts of the same pathway, they probably shouldn't be given together. ARBs tend to be utilized kind of as a secondary medication if ACE inhibitors were not working for the patient or with that uncomfortable side effect of a cough. You have to remember when the renin-angiotensin-aldosterone system, that whole pathway is a life-saving mechanism. And so what happens is it helps the body detect when to hold on to fluid and when to get rid of fluid through a series of hormones that talk to target tissue. And so when we mess with that system, there's a potential for the body to not know what to do in the case of emergency. And so for that reason, we don't want to give multiple medications that act along that same pathway. So we don't usually see ACE inhibitors and ARBs given together. Now, that's not to say you're never going to see that, because I have seen it, but it's definitely something that you can question. It's playtime right now with Levi. So if you hear things knocking over, his tail is wagging and he's starting to harass the cats, but we'll just keep going. There are other medications that you'll probably talk about in pharm that lower blood pressure, but the last one I'm going to just mention are beta blockers. We use these quite a bit. They aren't just for hypertension. We see them a lot for patients who have other medical conditions like MI or something like that. And they work in in the beta receptors. There's beta 1, there's beta 2. Receptors in the heart and in the lungs, and they slow down the heart rate and they lower the blood pressure through that particular system. So a little bit kind of different thing there. So anyway, those are some pharmacological interventions. Anytime we give somebody a medication that's going to lower their blood pressure, we have to be concerned about are we lowering the blood pressure too much? Let me just jump back here for a second. Are we lowering the blood pressure too much? And how do I know if my patient's blood pressure is too low? If we're not getting enough perfusion, we're going to start to see signs and symptoms like weakness, dizziness, fatigue. This is where we might see syncopal episodes because the blood pressure drops too low, clammy, sweaty type of skin. So just something to be aware of, especially if we're starting a patient on a new blood pressure medication. We just want to keep them safe. Okay, one last thing about hypertension, and that's either there's an urgent or an emergent situation, and we've got hypertensive crises. So urgency versus emergency just depends on how high the patient's blood pressure is and what kind of symptoms they might be having in association with that. So if we're in a hypertensive urgency, then we need to reduce that blood pressure within 24 hours. They're probably going to get oral medications with close follow-up on an outpatient basis, but these patients aren't going to have evidence of target organ damage. We don't want to lower the blood pressure too quickly because we want to maintain good perfusion, but we do want to reduce the blood pressure to 160 over 110. Wow, that seems so high. But if we're talking about hypertensive urgency, then it means our blood pressure is going to be way over 200 systolic. You can see that some of the medications that we might use for that are ACE inhibitors, calcium channel blockers, or beta blockers. Now, hypertensive emergency is a concern because there's potential target organ damage. Things like kidney damage, heart failure, stroke, heart attack, aortic dissection. We're starting to see potentially significant systemic damage. We're going to put these patients on IV antihypertensive medications, particularly nitroprusside, maybe nitroglycerin, maybe labetalol. But the goal, again, is not to lower the blood pressure too quickly because we still want to maintain tissue perfusion. And if we lower it too quickly, we're not getting blood flow and oxygen to some critical organs, such as our heart or our kidneys or our brain, and could result in some pretty disastrous kind of effects. So just an emergency of too high of a blood pressure. So big things about blood pressure: we have some good medications to manage it, and we have some good lifestyle interventions that we can utilize to teach our patients how to reduce their blood pressure without or in conjunction with pharmacological intervention. But again, very, very common problem that we see in our patients. Okay, let's talk a little bit about coronary artery disease. What is coronary artery disease? Well, basically we have a buildup of plaques within the vessel walls of the coronary arteries, and those are the arteries that are in the heart. This buildup leads to narrowing of those vessels, and thus perfusion is altered. And when blood flow can't get to the heart muscle, then oxygen also cannot get to the heart muscle, and we end up having symptoms that are potentially lethal. So for example, this is where we get into angina and we get into myocardial infarction. Both of these are because of narrowing of those coronary arteries where we're not getting good perfusion and oxygenation. Go get it. Okay, again, we have modifiable and non-modifiable risk factors, and lifestyle is a big part of that. We have a variety of different things that we can educate patients about. Again, you'll see that these are almost exactly the same, if not exactly the same as those that are present for hypertension. Things like smoking, high cholesterol, inactivity, obesity, excessive alcohol consumption. Again, with some of those secondary types of problems like diabetes, metabolic syndrome, stress, all of those things, we can intervene there, and we can modify those risk factors and help reduce the risk of coronary artery disease. Okay, so coronary artery disease brings us to what's known as angina, right? And angina is basically chest pain. When the heart muscle cannot get oxygen because of poor perfusion, then we experience chest pain, all right? So that is what's happening when a person has angina. We have a few different ways in which we can describe or categorize angina or angina, however you like to say it, dealer's choice. And those terms are based on what that manifestation looks like, or how it presents, or how it responds or doesn't respond to our treatment. So a stable angina means that we know that chest pain is triggered because of a certain activity or degree of exertion. And we know that when we stop that activity that led to that chest pain and we rest or we use a vasodilator like nitroglycerin, that chest pain goes away. That's a stable angina. It's predictable. An unstable angina then is unpredictable, which means it may occur in response to varying degrees of exertion, and it increases over time, and it doesn't really get any better. Well, intractable angina would mean that it doesn't really get any better. It doesn't matter what the treatment is, it doesn't get any better. And then I'm not going to talk about all of these, but then there's silent angina, which a person doesn't have any symptoms, but they're experiencing EKG changes. And to me, that's the scariest one. You've got this stuff going on in your heart where it's not getting blood flow, and you don't even know it. That'd be scary. Okay, so when we think of angina, when we think of chest pain, that's what we think about. You have, someone's grabbing their chest. They have discomfort in their chest. It's oftentimes described, go get it, as a crushing feeling. It usually lasts less than about 5 minutes. And then with rest, it will oftentimes go away. People may also report squeezing or burning or pressure. It can vary in severity, whether it be mild or moderate. A person may also experience other symptoms like dizziness or sweating along with it. Women sometimes have atypical type symptoms. Sometimes I've seen them just be fatigued or ultra tired. They have like GI upset. They just don't feel good. So we just have to be really aware that some people have atypical symptoms of chest pain or angina. And if someone is experiencing something that you think could be the heart, it's never going to hurt to get an EKG. That's very quick, very easy to do. But the big things about angina is it's typically worse with activity, and then it usually gets better with rest. Or with intervention like nitroglycerin. Ouch. Okay, so when we talk about medical management of angina, we're trying to relieve pain, we're trying to restore blood flow, and we're trying to prevent further attacks. So how do we do those things? Well, when someone has an acute onset of angina, sublingual nitroglycerin is really great. This is a vasodilating medication, which means it's going to open up the blood vessels. So if I have chest pain because my blood vessels in my heart are narrowed and I open those up, it makes sense that as that blood flow and oxygenation is restored, that my chest pain is going to get better. When they're diagnosed with angina and they have nitroglycerin, there's a few things we have to educate them about. Number one, nitroglycerin needs to be kept out of the light. So this is why you'll find it in like a brown glass bottle, because it's light sensitive. It also should not be held close to your skin, so you probably shouldn't keep it in your pocket or anything like that. I've known some people to carry it in a necklace. I don't know. You probably shouldn't do that. We want to educate patients, take one nitroglycerin and rest. If you're experiencing chest pain, wait 5 minutes and then you can have up to 3. At the second one, after you've taken the second dose, if you're still experiencing chest pain, you probably need to call 911 and get emergency medical help. But you can go ahead and take a third one. As far as prevention, long-term prevention, we may put people on a long-acting nitrate. So that's something like Imdur. That's mononitrate or something like that. And that is going to be a long-acting vasodilating medication. Beta blockers, those LOL drugs, as well as calcium channel blockers, might be prescribed. The beta blockers are going to reduce the workload on the heart, make it have less work to do. So you have to think about it. Think about when you're running up the stairs, you need more oxygen because your muscles are working, your lungs are working. Well, the same is true for your heart. If I take the workload off my heart, get out of there, shoo, then it's not going to require as much oxygen, which means I'm not going to have the chest pain. So beta blockers are going to reduce the load of the work on the heart, so it doesn't need as much oxygen. Calcium channel blockers, they cause vasodilation, so they can be given for angina as well. And the reason that we give antiplatelet agents is often because the reason that a person has this angina, again, as we mentioned, this coronary artery disease, is because they probably have atherosclerosis or a buildup of plaques. So not only might they beyond statins, but antiplatelet agents are going to prevent platelets from sticking to those plaques that are in the blood vessel or coronary artery walls. So we're doing all of these things to help prevent a complete occlusion of a coronary artery, the antiplatelet agents, opening up the blood vessels, all of those kinds of things. Okay, so what do I do when my patient comes into the hospital and says, I have chest pain? Well, the first thing you're going to do is you're going to make sure they're not having a heart attack. That's what we're looking for. And in order for us to determine if a patient's actually having a myocardial infarction, we have to get an EKG. An EKG is going to tell us if there are changes within that electrical conduction system that are consistent with evidence of infarction or ischemia. And so there's a standard of getting the EKG within 5 to 10 minutes of presenting with complaints of chest pain. The next thing we're going to do is when a patient is complaining of chest pain is we want to, of course, hook them up to a heart monitor and, start getting vital signs, what have you. But we're going to be giving them nitroglycerin, and we'll give them sublingual nitro in the hospital setting just as we did educate them about the outpatient setting. They'll get one sublingual nitroglycerin tablet under the tongue, and we can give that every 5 minutes until pain is 0. Now, in the past, we've talked about how 0 is an unrealistic goal for pain, but when we're talking about chest pain, that's what we want. We want 0 chest pain. So if a patient is reporting a pain of a 9 or a 10, and you give them a nitroglycerin and they're like, oh, that's better, you don't want to hear that's better. You want to hear that it's gone. So you kind of have to be a little bit staunch about saying, well, I want it to be a 0 because we really want the pain to be a 0. Again, we can give that nitro every 5 minutes, up to 3 doses. And that's a vasodilator, so we have to watch our patient's blood pressure. If their blood pressure drops too low, then that may be something that prevents us from giving them more nitroglycerin. Another thing we're going to do is we are going to give the patient aspirin, and we're going to have them chew aspirin, and it's 325 milligrams or 4 baby aspirins they're going to chew. That's an antiplatelet medication. It has nothing to do with pain whatsoever, but we're trying to reduce the likelihood that platelets are going to stick to any types of plaques and just kind of keep those coronary vessels open. So that is the N and the A. The M in MONA stands for morphine. Morphine can be given to help with pain related to angina because it also has vasodilating effects. So we might see an order for morphine. And oxygen is only indicated if our patient's O2 saturation is less than 92%. So if your patient comes in complaining of chest pain and their oxygen saturation is 98%, then we probably don't need to administer oxygen. So hopefully, if our patient comes in and they're complaining of chest pain, if there's no significant EKG changes, we're giving them nitro, we're giving them aspirin, we may be giving them morphine, we may be giving them oxygen, and then we're kind of working them up to see if there's anything else that is going on. Are they showing evidence of ischemia or tissue damage with an elevation in a CPK or troponin, things like that. If there isn't any of that, maybe this is the first time the patient's had this angina, then we start thinking about the long-term management, lifestyle changes, dietary management with her healthy diet, just like with hypertension, smoking, drinking, getting rid of all of those things, and probably starting on some sort of pharmacological intervention like a beta blocker or calcium channel blocker or what have you, statins for cholesterol. All of that kind of thing. Now, if our patient does not get any better, they have an unstable angina, we get an EKG and we're seeing EKG changes that are consistent with a myocardial infarction, then our pathway gets a little bit different. We're still going to do oxygen if needed, nitro, aspirin, morphine. This patient's also going to get a beta blocker. That's pretty standard. And they're going to start putting them on other medications too. They may be placed on a nitroglycerin drip. They may be placed on a heparin drip. And we're trying to save as much heart tissue as we can. So we're trying to keep the vessels as open as we can. Patients can basically have two.
This is just to show.
I missed one. Two different types of an MI. There's an ST elevated MI, and then there is a non-ST elevated MI. So if you've heard of STEMI or non-STEMI, that's what those refer to. At the left side of this slide, you can see what a normal cardiac complex looks like with your P, Q, R, S, and T waves. All the complexes and segments are kind of outlined for you there. Depending on what part of the heart is affected, you might see different changes within the ST segment being depressed or the ST segment being elevated. And again, this is advanced reading. EKG type stuff is advanced reading.
And then here's a closer.
Oh my goodness, I forgot that one too. Sorry about that. But see here on the left and the right, you see this ST elevation. That would be somebody is having a STEMI. When somebody is experiencing a STEMI where they have ST elevation, they are a prime candidate for immediate intervention. And we'll get to that here in just a second. So how is an MI different from angina? Well, just think about it. Angina is something that goes away, right? The stable angina does, right? When we get to that unstable angina that doesn't go away and we start to have signs and symptoms of alterations in perfusion, then we're seeing clinical manifestations of myocardial infarction. So they have the chest pain, but it's not getting any better with intervention. They may have pain that radiates to other places like their jaw or their back. Sometimes we see nausea, sometimes we see dizziness, sometimes we see anxiety or shortness of breath. Again, this might vary a little bit, but what we're looking at are alterations in perfusion because we're having a blockage within those coronary arteries and it's really affecting us. So we want to make sure that we're starting care on our patients as quickly as we can, getting that EKG, identifying that ST elevation or depression, what kind of myocardial infarction the patient's having, giving them nitro, giving them morphine, starting them on heparin or nitro drips or whatever the case may be. But we want to identify it, we want to stop the pain, restore perfusion and oxygenation in order to save heart tissue. So this is kind of what I've talked about, right? Like chewing an aspirin, looking at what kind of MI is it, is it STEMI or non-STEMI, and we do that through an EKG, and getting them what they need to help resolve their pain, oxygen, nitro, starting IV lines, giving fluids, getting them to the right level of care, starting them on heparin or whatever it is that they're needed to be started on to help facilitate perfusion and oxygenation. Now, if a patient has a STEMI, they're a prime candidate for percutaneous coronary intervention or PCI, and that's where they go to the cath lab. When a patient has a STEMI, there are certain criteria how quickly we need to get them into the cath lab, and it's very fast. So if you have a patient come into the emergency department having a STEMI, it's going to move very, very quickly as that cath lab team gets called in, because the faster they can get that vessel open, the more likely they're going to save that heart tissue. With a percutaneous coronary intervention, or heart cath, they take a catheter and put that into an artery, and they thread it all the way up to the coronary arteries wherever the plaque's at, and they might put a stent in there. And basically, as you can see in this picture, a stent is something that is like a scaffolding, and it just pushes back that plaque that is occluding that vessel and creates an opening for blood flow to get through. During this procedure, they will be able to identify which coronary artery is occluded by injecting dye into that catheter and then getting an image of where that dye goes or where it doesn't go, where it kind of has a roadblock in there. So that is what a heart cath is. This picture, you can kind of see they're introducing that catheter in through the femoral artery, which they do still do, but I'm seeing more and more a brachial artery access. There's less complications. The patient can get up and move a lot more quickly, more sooner. And so I just am seeing more brachial. I think I've even seen radial access recently as well. When a person comes back from a cath lab procedure like this, there are special precautions that you would have to do in terms of keeping the patient still. Ouch, sharp teeth. Patient still, because they did cannulate an artery, and so they can't move that leg or move that arm for a particular period of time because of the risk for bleeding. A patient might also need surgical management if they have very extensive occlusions with something called a coronary artery bypass graft surgery. When people say they have had a CABG, that's what they're talking about. So they will harvest a vein from a distal site and then use that to basically make a new pathway for the blood flow to go through, because part of their own anatomy is just so completely occluded that blood flow can't get to it. So that would be potential surgical management for someone who has had a heart attack. They probably don't. They would probably do a heart cath first, and then recognize that they are going to have open heart surgery. I don't want to play fetch anymore. I'm trying to record a lecture. Go away. Don't look at me like that. Okay. Moving on. Let's talk about chronic heart failure. So, when we think about the heart, again, there's 4 essential components of heart function. It needs to be able to contract, right? That's a good thing, because that's how we squeeze blood. We need to have a certain amount of blood in the ventricle at the end of diastole before it gets to contract again. So it needs to be able to refill, right? That's preload. We have to have the right amount of pressure against which that left ventricle ejects. That's the afterload. And then we have how fast is the heart beating. So when we think about chronic heart failure, we're looking at abnormal loading conditions. We have a volume, an increase in volume. When persons have chronic heart failure, we have a difficulty in managing volume. So we have an excessive stretch and a decrease in the contraction of that muscle. The pressure or the force, the ventricle has to work harder against that because there's more volume and there's likely greater resistance that it's working against. We have an abnormal muscle function. In other words, our heart muscle is damaged either with scar tissue because of an MI or something of that nature, or just years and years of overworking the heart. Something like an infection, maybe like pericarditis or something like that, can lead to this as well. Or really any condition that increases oxygen demand. So for example, patients who have chronic lung disease are at risk for developing chronic heart failure, right? Because we're increasing the amount of work that the heart has to do. We see ventricular dilation, which is when the muscle fibers lengthen, which increases the volume inside of the heart chamber, but it's not a good thing that we have this extra volume in here. Right? This is going to increase our preload, or that amount of blood that's left in the ventricle at the end of diastole. And so our body tries to compensate by increasing the size of the muscle. And remember, we don't want big, giant heart muscle because then we have less room for blood to refill in there so that we have good perfusion. So we end up having this tissue that's just not as effective as what it once was, and our vessels and our this bigger heart requires more oxygen, which means that we're going to have more potential problems with maybe angina, and then the heart muscle's not going to work as well. So you see, it's like this whole cascade of problems that can occur. Ultimately, what happens is we have a decrease in cardiac output. That means the amount of blood that comes out of the heart is decreased. And so therefore, we have a decrease in perfusion or blood flow to distal sites. Our body just can't handle all of the fluid, and so then things start to back up, and the renin-angiotensin system starts to get activated, and we have sodium and fluid retention, and our blood pressure goes up, and our volume in our system kind of increases. So that's what we're looking at when we're talking about chronic heart failure. So basically the heart cannot pump enough to meet the needs of the body, all right? And so what our body does is it tries to increase the heart rate. It tries to increase, how hard the heart is contracting. It tries to increase the amount of resistance. It tries to increase the output. And then we have this damage that leads to too much volume, not enough perfusion, and just generalized weakness. There are classifications of heart failure in terms of, they refer to it as systolic or diastolic heart failure. One of the tests that we look at is something called an ejection fraction. Anything above 50% is considered to be normal ejection fraction, and anything less than that is considered to be some sort of heart failure. We can also differentiate heart failure into left and right heart failure, and I'll show you what the difference between that looks like. So who's at risk for developing heart failure? You can see here this is a very similar list to what we've seen previously with our other cardiac conditions. So there's nothing new there. All of these things are making the heart have to work harder, and over a long period of time, we're seeing significant damage related to that. If a person has right-sided heart failure, they might look a little bit different than someone who has left-sided heart failure. So with right-sided heart failure, we're going to see backflow of blood into the right atrium and venous circulation, leading to jugular venous distension, generalized edema. Ascites is accumulation of fluid in the abdomen. And a person who has left-sided heart failure can ultimately end up with right-sided heart failure too. So then both sides of their heart are not working. Left-sided heart failure is more about the lungs. This is where we see pulmonary congestion with crackles, shortness of breath, dyspnea, pulses can be altered, temperature of the extremities. So in MedSurg 1, we talked about fluid volume overload as a combination of all of these symptoms here. In MedSurg 2, we're differentiating between which side of the heart is not functioning in terms of where that volume is going to end up. So to me, this looks like a good select all that apply question on a test. I don't know. I'm just saying. Okay, so we're looking for structural abnormalities like a weak or thickened walls, electrical changes in our EKG, fluid buildup in the lungs, enlargement of the heart. We can do that through these tests that are listed here at the top. An echocardiogram, if I didn't say this, is kind of like an ultrasound of the heart. Cardiac enzymes such as CPK and troponin could potentially be elevated. We might see a change in liver enzymes if we're seeing liver congestion. BUN and creatinine can be altered. We might see some differences in urinalysis or urine-specific gravity depending on how much fluid the patient's trying to get rid of, or their ability to concentrate sodium and all of that kind of thing. BNP is the one lab that I talked about earlier. Hey, stop it. She doesn't want to play. Go away. That I talked about earlier, that when there's an increased stretch on the aorta, then it releases this hormone and it tries to get the kidneys to get rid of the extra fluid. So when you see an elevated BNP, your body is trying to get rid of the fluid. But when patients have congestive heart failure or chronic heart failure, it's just not enough. They're just not able to manage all of that. And the higher the BNP, is correlated with greater exacerbation of heart failure. I'm about to go down over here. Okay, so how do we manage a patient who has heart failure? Well, we need to control the volume, and we need to reduce the workload on the heart. And we're going to do those things through medications and lifestyle management, right? So diuretics are pretty much a mainstay for chronic heart failure. Patients will be on some sort of diuretic to help get rid of extra fluid, and that will reduce the workload of the heart by reducing both preload and afterload, because there's just not as much fluid that the body has to deal with. We may also place the patient on some sort of beta blocker, because it's going to, just depends, on the overall state of the patient, because that's going to reduce the work on the heart. If a patient requires is having shortness of breath because they're not getting enough oxygenation, we might have to put the patient on oxygen to maintain that. We have a lot of lifestyle management things that we can do, like sodium restrictions. Sometimes a person has to be on fluid restrictions depending on the severity of the heart failure. But as far as preventing exacerbations, we want to make sure that the patient is following the instructions on all of the things that they need to do to keep their heart as healthy as they can. And that's what we see here. Are they taking their meds? Their diuretics are important. Their other cardiac medications are important. Are they eating foods that are low in sodium? Are they monitoring their weight every day? Patients who have heart failure should be taking daily weights, and if they don't have a scale, we need to get them one. They need to be taught to weigh themselves at the same time every day, wearing the same type of clothing and keeping track of that. And if they gain more than, I think it's 2 pounds in a day, or might be 5 pounds in a week, they need to be reaching out to their provider. They need to monitor their vital signs and for other signs and symptoms of potential fluid overload, whether that be edema or trouble breathing, or an increased in their activity intolerance, meaning they're not able to get around and do as many things as they were before because they get tired or short of breath more quickly. Whatever that case is, they need to be monitoring themselves for symptoms, because the goal here for these patients is to keep them out of the hospital. So if they know that if their blood pressure gets high, or their breathing gets compromised, or they start to have weight gain, or they start to have signs of fluid excess, then they can be reaching out to the providers before they get bad. We might position a patient in a high Fowler's position just to kind of help with their breathing if they happen to be having some breathing difficulties. And then we want to make sure that they're as mobile as they can be. When a person has a heart that doesn't function like it's supposed to, it can be hard to stay mobile. So just, maybe teaching some chair exercises and doing as much as they can and conserving energy, or, kind of spreading their workout throughout a period of a day. Let's see, what else do I want to say about heart failure patients? What do we do for heart failure? Intake and output, daily weights, monitoring for edema. Lung sounds are important because we're looking for pulmonary congestion. We're looking for jugular venous distension. All those signs of the different types of fluid volume excess. Making sure they're on their diuretics, taking those cardiac medications like they're supposed to decrease the workload on the heart. Digoxin, that's a good pharm medication that they like to talk about. Digoxin has a positive inotropic effect, which means it makes the heart contract harder. So if I have a harder squeeze, then more blood flow is going to get out and increase perfusion. If I have better perfusion, I can get rid of that fluid and manage that fluid a little bit better. Digoxin is an old drug. We just don't use it nearly as much as we used to, and it has some really gnarly side effects to it, as you've been learning in pharmacology. It's very easy to become toxic with digoxin. I think in all the years that I've worked, and granted, I'm not a cardiac nurse, so you have to take this with a grain of salt. I think I've only given digoxin maybe 3 or 4 times. It's just there are newer drugs that are more effective. They're using ACE inhibitors and stuff in combination with diuretics that are managing our patients with chronic heart failure better than digoxin without all of the potential nasty side effects. Okay, what other kind of management might we do? Okay, so if a person has very severe heart failure, they might require certain types of surgical intervention, whether that be a defibrillator that's going to help basically reshock the heart if it were to go into a deadly rhythm like a VTAC or something of that nature. You can see on the left here a ventricular assistance device, which is an external piece of machinery that helps the ventricles squeeze harder. And then ultimately, heart transplantation could be a thing for these people. So just a little bit there about surgical management. All right, I think that's pretty much it for the day. We've kind of progressed from blood pressure into coronary artery disease, how that impacts and plays into angina and ultimately MI. And then as that cardiac tissue is affected and dies, we could end up with congestive heart failure. So we will be working on a couple of case studies in class this week. Thanks for listening, and let me know if you have any questions.